Gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman, and thank you for holding this important hearing. I also want to commend my colleague, the gentlewoman from North Carolina, for her eloquent and thoughtful statement on a very important topic. And while I disagreed with what some of my colleague from Georgia said, I have great respect for his real-world experience on women's health issues and appreciate the concern he brought to this hearing. But I also want to talk about the comments that were made by the Chairman Emeritus and others on this committee. If people don't believe that rationing takes place right now in our private insurance system, every day in every state, in every congressional district, they are sorely misguided. It does happen every day under the current system, which is failing to meet the needs of the American people. I'll give you a good example of a friend of mine who was diagnosed with prostate cancer and conferred with his physician on treatment options and agreed that proton beam therapy was the best choice of treatment for him. And he went to his private insurance company, which also is the Medicare administrator in my state of Iowa, and his treatment was denied on the basis that it was experimental. Well, guess what? Under the Medicare plan that same private insurance company administered, it was considered non-experimental, and even though he was eligible for Medicare because of his age, he was still covered by a private plan through his employer and was denied coverage for the same treatment he would have gotten if he had been a member of Medicare. That's what's wrong with our broken health care delivery system, and that's why comparative effectiveness research is such a critical part of a rational discussion about health care policy making. In an earlier hearing in this same subcommittee, I talked about a hearing that took place in this very room years ago when a researcher advocating high-dose chemotherapy with bone marrow transplant for metastatic breast cancer patients was the only path to cure for those women, even though it had not been tested by rigorous academic research. Then, years after that, we came to the realization that many women were actually harmed and died because of being subjected to that treatment. And that is why, by the way, it is so important that the plain language amendment that I put in the health care bill be implemented in people dealing with health care issues. I think that in its position paper, the U.S. Preventive Services Task Force highlights why that is so important. They indicate on one page of their statement that the problem was a matter of communications because they did not say what the task force meant to say, that the communication of the mammography screening recommendations was poor. Well, I agree with that, and all you have to look is the next two sentences to find out why. This is what two of the sentences say. We said is that screening starting at age 40 should not be automatic, nor should it be denied. That doesn't make sense. The next sentence says, what we are saying is that a decision to have a mammogram for women in their 40s should be based on a discussion between a woman, her doctor. If you don't communicate for your intended audience in language that they can comprehend easily, these barriers of communication between highly technical, scientific, and medical information will be a problem. But the debate we're having is a healthy debate about what the most effective use and treatment for breast cancer patients is, and that's what we need to focus on going forward. And I yield back my time.